Hi everybody, and welcome to our first video on renal physiology. Let's start by talking about fluid compartments. The body is made up of 60% water and 40% non-water, and most of that 60% water is found inside of cells. 2/3 of the body water is intracellular, and only 1/3 is outside of cells or extracellular. And of that fluid that is extracellular, 1/4 of it is found in the plasma, so in our vascular system, and 3/4 of it is found in the tissue beds. This is called interstitial fluid. The reason we know how much fluid is found in the different compartments in the body is because of experiments that determine fluid volume. So to understand these experiments, consider that if we took 1 gram of a substance and added it to 1 liter of fluid, we would then get a mixture that had a concentration of 1 gram per liter of that substance. In an experiment, what we can do is add 1 gram of a substance to an unknown volume of the body and then measure its concentration. If we determine that the concentration is 1 gram per liter, then we can back calculate that the volume into which we added that gram must have been 1 liter. And this is the way these experiments are done to determine the volume of fluid in a particular compartment of the body. The two classic substances used experimentally to determine the volume of fluid compartments are inulin and radiolabeled albumin. Inulin is a substance I talk about a lot in the second renal physiology video because it can be used to estimate the glomerular filtration rate. But one of its properties is that it remains in the extracellular space, so you can infuse inulin into a patient, measure the concentration, and determine the volume of the extracellular fluid space. Radiolabeled albumin is just a version of albumin that can be measured experimentally, and albumin has the property that it stays in the plasma. It does not cross capillary membranes, so if you infuse radiolabeled albumin and you measure the concentration, you can determine the plasma volume. So the way these experiments are done is shown at the bottom of the screen. For example, if you infuse X grams of inulin into a research volunteer and the equilibrium concentration is Y grams per liter, then in the case of inulin, which stays in the extracellular space, the extracellular fluid volume will be X divided by Y liters. And this is easier to understand if we use some actual numbers. So suppose we infuse 10 grams of inulin into a research volunteer and the equilibrium concentration in the plasma is 0.25 grams per liter. Then for that research volunteer, the extracellular fluid volume must be equal to 10 divided by 0.25 or 40 liters. So in this manner, we've determined the volume of the extracellular fluid compartment. The same thing can be done with radiolabeled albumin, and this will give us the volume in the plasma. Sometimes on your board exams, the questions will be a little bit more complicated with more math, so let's go through an example of one of those now. Suppose a patient is administered 120 milligrams of inulin, and an hour later the patient has excreted 20 milligrams of inulin in the urine. At that point in time, the plasma inulin concentration is 1 milligram per 100 milliliters, and they ask you, what is the extracellular fluid volume for the patient? Now, this looks like a lot of numbers, but actually it's very straightforward to answer this question. The amount of inulin in the body for the patient is the 120 milligrams that was infused minus the 20 that left in the urine for a total of 100. The steady state concentration they tell you is 100 milligrams per 100 milliliters. That means that the extracellular fluid volume, which is what they're looking for in the question, is 100 divided by 0.01 milligrams per milliliter, or 10,000 milliliters, or 10 liters. It's a lot of numbers, but very simple math gives you the answer to these types of questions. Now let's talk about how fluid volume shifts between the different spaces in the body. You should be aware that plasma osmolarity is about 300 milliosms per kilogram, and there is an equilibrium established between the fluid inside of cells and the extracellular fluid. And fluid volume is only going to shift from outside of cells to inside of cells if a difference exists in osmolarity. So for example, let's imagine that we have a cell, and inside the cell the osmolarity is 300 milliosms. We can add all the volume we want of fluid at 300 milliosms to the extracellular space. None of that volume will move inside of the cell. It's only going to move inside of the cell if there's a difference in osmolarity between what's inside and what's outside. Now let's imagine we have a cell with 300 milliosms inside of it, and we start adding fluid around it that has an osmolarity of 200 milliosms. In this situation, the fluid is more concentrated inside the cell, so volume is going to be drawn inside of the cell and the cell is going to swell. The opposite would happen if we added volume around the cell that had a higher osmolarity than what's inside the cell. So you have to understand this basic principle that you can add or take away volume all you want from the extracellular space, but it is only going to move into the intracellular space if there's a difference in osmolarity between what's inside the cell and what's outside the cell. There are many clinical situations in which we see the addition or loss of isotonic fluid. This means fluid that has the same osmolarity as plasma. In this situation, the extracellular fluid volume is going to change, but there will be no change in the intracellular fluid volume, and that's because the fluid that is being added or lost to the body is isotonic with plasma. So for example, in the setting of hemorrhage, patients are losing plasma, so they are going to lose lots of extracellular fluid volume, but the volume inside of the cells is not going to change. Another classic clinical example is the infusion of normal saline. Normal saline is a commonly used resuscitation fluid for patients who are hypotensive, and the reason we like to use it is because it has almost the same osmolarity as plasma. This means it will raise the volume in the extracellular fluid compartment, including in the vascular system, but none of it will move to the intracellular space, so there will be no significant change in the ICF. Now consider what would happen if we infused a solution of 5% dextrose into a patient's veins. This is something we sometimes do clinically. This solution is hypotonic compared to plasma. That means it has a lower osmolarity compared to plasma. What this will do is increase the extracellular fluid volume, obviously, because we're infusing solution into a patient's veins, and the veins are part of the extracellular space. But in addition, we are going to increase the intracellular fluid volume. That's because this is a hypotonic fluid. It has a lower osmolarity compared to what is normally found inside of cells, so water will be drawn into the intracellular space. Another classic example of these principles of how fluid shifts between compartments is a mannitol infusion. Mannitol is a drug that is osmotically active, and it raises the plasma osmolarity. In addition, it remains in the vascular system and does not go into the extracellular space. So what mannitol is going to do is draw fluid out of cells and decrease the ICF volume. It's going to increase the extracellular fluid volume. However, that volume increase is all going to be inside of the plasma. The volume of water in the interstitial space is going to decrease. And this makes mannitol the ideal drug in patients with brain swelling. You can draw fluid out of brain cells and out of brain tissue and into the plasma. Now let's talk about an important renal and cardiovascular physiology concept, and that's called the effective circulating volume. This is a volume of fluid in the body that you never actually measure. It's just a theoretical concept, and it's the portion of extracellular fluid that's contained in the arterial system and maintains tissue perfusion. In certain disease states, the body can have lots and lots of fluid, but actually very little of it is perfusing tissues. Those patients have lots of water in the body, but they actually have a low effective circulating volume. So this concept is used to explain situations where even though the total body fluid may be up, the effective circulating volume of fluid is down. So as I state here in the slide, this volume is not necessarily correlated with total body water. The major factors that affect the effective circulating volume are the volume of fluid in the vascular system, the cardiac output, and the vascular resistance. In the videos on hypertension, I talk about how your blood pressure is influenced by two major factors, your cardiac output and your total peripheral resistance. The same is true of the effective circulating volume. The cardiac output can go down when there's not much volume in the body, and this cardiac output can also go down if there's a problem with the heart and there's low cardiac output. Both of these lower the blood pressure. They also lower the effective circulating volume. And then anytime the vascular resistance is reduced, that will lower the blood pressure. That also can lower the effective circulating volume. The reason this concept is so important to understanding disease states is because a low effective circulating volume leads to low blood pressure, and it activates two important physiologic systems, the sympathetic nervous system and the renin-angiotensin-aldosterone system. So any time the effective circulating volume is low, these two systems will become active, and that's critical to understanding certain disease states. To understand this, let's look at the chart I've drawn on the screen here. So let's imagine we have a patient with volume depletion. For example, maybe this patient has hemorrhage, or maybe they have nausea, vomiting, and diarrhea, and they're massively volume depleted. That patient will obviously have relatively little total body water. There's not much water or fluid in their whole body. And that patient will also have a low effective circulating volume. So this will obviously activate these two systems, which are a major part of how we respond to volume depletion. Now consider a patient who has heart failure. This patient has a low cardiac output. Patients in heart failure are congested. As I talk about in the cardiology section, they have swollen neck veins and swollen legs. Their total body water is very, very high. But even though it's high, their effective circulating volume is low. It's not low because there isn't enough water in the body. It's low because they have a problem with their heart and low cardiac output. So just like in volume depletion, patients with heart failure have activation of these two systems, and you need to understand that to understand the pathophysiology of heart failure. Finally, let's consider cirrhosis. Patients with cirrhosis are massively vasodilated. They have a very low peripheral resistance or systemic vascular resistance. Both terms mean the same thing. These patients have lots of total body water. They have ascites, they're swollen and full of fluid, but their effective circulating volume is very low, and that's because of the low SVR. So they also have activation of these two systems as part of the pathophysiology of the disease. So the key point here is that you need to understand this concept of effective circulating volume, which is not necessarily the same as total body fluid volume. Anytime this effective circulating volume drops, that will activate the sympathetic system and the RAS system, and that's key to understanding the pathophysiology of all three of these disease states shown on the screen here. Now let's talk about how we evaluate kidney function. So imagine we have a number of patients and we want to know how well their kidneys are functioning. How are we going to do that? Well, the key measurement that we typically use to estimate someone's kidney function is called the glomerular filtration rate. This is a measurement of how much liquid passes through the filter, i.e. the glomerulus, per unit time. And you can determine this from plasma and urine measurements. And I'll talk about how to exactly determine the glomerular filtration rate, in other words, to get a number for this rate in the second renal physiology video. But the reason we like to evaluate kidney function with the GFR is because it falls as the kidneys fail. As the kidneys start to get sicker and sicker, they filter less fluid and the GFR falls. There are some other metrics of kidney function that we also use. One is the amount of blood or plasma flow. This is how much blood is entering the kidneys. And the other one is called the filtration fraction. So this is the ratio of the GFR to the renal plasma flow. So for example, if the renal plasma flow is 10 liters per minute, but only 5 liters per minute are being filtered across the glomerulus, that would give us a filtration fraction of 50%. And this is another measurement we sometimes use to talk about how healthy the kidneys are and how well they're functioning in health and in disease states. As a student, I recommend that you think about the measurement or the determination of the glomerular filtration rate in two ways. One way is the theoretical determination of GFR. This is what I'll focus on in this video. This has to do with the pressures and the forces in the capillaries and in Bowman's capsule that determine the GFR. The second way to think about GFR is the clinical determination. This is the way to actually calculate a number for the GFR. To do this, you need plasma concentration of solutes and urine flow, and I'll talk about all the math in measuring the actual number for GFR in the second renal physiology video. In order to understand the theoretical determinants of the GFR, you need to understand the driving forces for glomerular filtration. And there are basically two forces that drive solutes and fluid across the glomerular membrane and into the nephron. Those two forces are the hydrostatic pressure in the capillaries and the oncotic pressure in the capillaries. So we're going to talk about both of these and how they affect and determine the GFR. Shown on the screen is my own drawing of a glomerular capillary. So let's imagine that we have fluid flowing into this capillary carrying solutes. Some of the fluid and solutes will cross the glomerular membrane and enter into Bowman's capsule or Bowman's space. Others of the fluid and solutes will exit the glomerular capillary in this direction. So what we want to talk about are the forces that are going to determine the amount of fluid that crosses into Bowman's space. The first force is called the hydrostatic pressure. This is what you think about when you think about your blood pressure. It's the fluid force pushing against the walls of the glomerular capillary. And a high pressure tends to drive fluid toward a low pressure. So for example, if the hydrostatic pressure in the glomerular capillary were 10 and we had a hydrostatic pressure in Bowman's capsule of 5, then we would have a net driving force of 5 in this direction to drive fluid flow across the glomerular membrane and to create glomerular filtration. The other force that's important in the capillary is the oncotic pressure. This is a pressure created by solutes, especially albumin, and a concentrated solute tends to pull fluid into the glomerular capillary. And what's confusing about oncotic pressure is that a high pressure value tends to draw fluid away from a low pressure. So for example, if we had an oncotic pressure in the glomerular capillary of 10 and we had an oncotic pressure in Bowman's capsule of 5, that would tend to drive fluid in this direction. But nevertheless, it's just another force controlling fluid movement. And the summation of the hydrostatic pressure force and the oncotic pressure force is going to determine the amount of GFR. In other words, the amount of fluid and solutes that crosses this membrane and enters into the nephron. Here's a slide from the video in the cardiology section on regulation of blood pressure. In that slide, I talk about fluid exchange in the systemic capillaries. And I won't go through this slide now, but I just want to point out to you that the same two forces, hydrostatic pressure and oncotic pressure, control fluid movement into and out of systemic capillaries just like they control fluid movement in the glomerular capillaries. So getting back to the glomerular capillaries, what factors are going to change or alter the glomerular filtration rate? Well, if you want to change the glomerular filtration rate, you can change either the hydrostatic pressure in the glomerular capillary